All right, I think we're going to go ahead and get started here. Welcome, everyone. Thank you for joining us. My name is Dr. Chad Achenbach. I am the Associate Director of the Robert J. Havey, MD Institute for Global Health, and I am an Associate Professor of Medicine and Infectious Diseases and Preventive Medicine here at Northwestern's Feinberg School of Medicine. Thanks for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health's IGH Seminar Series. This talk is titled Emerging Infectious Diseases and the Long Arc of History, Infectious Disease Control, and Global Health Inequity. Please take a moment to follow us on Facebook as well as Twitter and Instagram, and our handle is @FSM Global Health. In addition, we welcome you to become an Institute member to receive access to specialized resources and services that support research infrastructure, particularly in global health. For more information, you can visit our website at globalhealth.northwestern.edu/members. We are thrilled today to host Dr. Sokhieng Au. She's from the program in Global Health Studies here at Northwestern. She's going to be presenting our seminar event. So Dr. Au has a really interesting, unique background. She's a medical historian and public health practitioner who's focused on health and illness in the global South. Her research examines medicine and disease broadly in both contemporary and historical perspectives. She has a particular focus on cultural, scientific, and technical exchanges or interventions and global health inequities in health, which is, as you all know, a big focus of IGH. She focuses her work in Southeast Asia and Central Africa. Prior to coming to us at Northwestern, Dr. Au worked with Doctors Without Borders, so really working in the field for many years, living in country. And she has researched and taught at many different universities throughout the United States, Europe, and Asia. Her very first monograph was a study of French colonial medicine in Cambodia, and her two most recent publications examined Belgian colonial medicine in the Congo and present-day antibiotic overuse in Afghanistan. She has a Ph.D. in History of Science from University of California, Berkeley, and a Master in Public Health from Johns Hopkins Bloomberg School of Public Health. There will be time for questions following the presentation. We welcome you to submit those through the Q&A feature at the bottom right-hand corner of the screen. So make sure to use that Q&A feature so we can see those questions. You can put those in throughout the presentation. But at this point, Dr. Au, I'll turn it over to you to give our talk.
Okay, thank you, Chad. I want to thank the Havey Institute and Kate and Meg for organizing this talk. We did it in a little bit of short notice. Let's get started. So this talk is actually, it's not exactly my research. It's sort of research tangential. It's a portion of the research that I have been working on in the early stages now for a couple of years. It's still the early stages. And there is this other project that I'm developing on healthcare under fire, the protective status of healthcare workers, and the perception or perhaps the reality of increased attacks on healthcare workers in humanitarian aid settings globally. And it relates to this issue of securitization, which is one of the issues that, well, it's a major issue that I'm going to talk about today with infectious disease, because my other big field of interest historically in terms of the history that I do is in infectious disease. And this notion of securitization is sort of important to, I believe, to the patterns that we see today in infectious disease burden globally, right? So I want to start with these two givens that most of us are probably pretty familiar with, right? And that is that low-income countries carry the mortality burdens for both infectious diseases and non-communicable diseases globally. Generally, they carry the majority of the burden. Infectious diseases represent a fraction of mortality in high-income countries, but a majority of all-cause mortality in low-income countries. And this is the pattern that I want to talk about today. It's a historically created pattern that I think is being reinforced by current global health frameworks, right? So the premise of this talk is that this inequity in the distribution of infectious disease in particular is a modern phenomenon. It's created by social, political, and historical processes that are being reinforced by current global health frameworks. I think we in global health think we're working against these inequities in what we do, but the problem is the overarching frameworks that we're working under, in fact, encourage a continued reinforcement of what began as historical processes of inequity, right? This is just two charts from Our World in Data. Everyone loves Our World in Data, right? That illustrate those two bullet points. Annual death rate from all-cause mortality. You can see that low-income countries, there's a much higher annual death rate per 100,000 people than high-income countries. So total burden, low-income countries. Infectious disease, low-income countries still carry a huge burden of infectious disease. High-income countries, their mortality of their all-cause death, their mortality pie is a very low fraction, right, of the burden that they carry. So how can we explain this current highly unequal global distribution of infectious disease mortality and morbidity? Well, it can be explained, of course, by history, policies, and practices. The current policies and practices, again, seem to reinforce this history that comes from colonialism, essentially, right? So as a sort of research presentation, there's two kinds of questions, two ways the questions can be asked. There's a theoretical question, and that is, how do we combine these frameworks to help us understand the current state of global infectious disease control? And then there's a practical question, and it's this question of how do we operationalize this knowledge to improve infectious disease governance and global health equity? One other thing that always strikes me, as I have moved from being a public health practitioner to an academic in the social sciences or the humanities, is a lot of what the humanities and social sciences do when we look at global health as an object of study, is somehow we get removed, we become distanced from the global health practitioner and global health practice as a process and the intervention itself. And so the findings in global health studies sometimes aren't meaningful to global health practice. That's something that I struggle with all the time because I often feel like I'm doing the one or the other, right? So let's talk about the history. And for some, this history might be very basic and you know it well already, and for others, it might be a little bit rushed. And so I apologize because I'm basically compressing into a few slides what I actually teach over about 2 10-week quarters, right? So infectious diseases in the modern era. Infectious diseases used to be predominantly, to be the predominant cause of human mortality 200 years ago everywhere, globally, right? We know this. People were dying everywhere, but equally, relatively equally. The toll of infectious diseases was pretty evenly globally distributed from about 1400 to 1800. If you looked at child mortality in 1850, it was bad everywhere. It was bad in Europe. It was bad in Latin America. It was bad in Asia. The estimates are that in 1850, about 25% of all infants died globally, and about 40% of children did not survive to puberty globally. And of those that did survive puberty to reach adulthood, less than 50% of us actually reached adulthood, right? Globally, everywhere. And this was driven by infectious disease. But you see this turning point in the 19th century, and I'm not going to go into this long history of high colonialism and the age of high colonialism, but in broad strokes, mid-19th century, Europe and the US started colonizing huge swaths of what we now call the global South, and for a variety of reasons, but it led to very similar outcomes, right? Extraction from the colonial state, disparate development patterns, governance structures that were unequal between obviously the metropole and the colony, things like that. But we also had in the same period in the 19th century, this tremendous, I don't want to overuse the word revolution, but a tremendous shift, sea change in what was happening in medicine, in public health, in sanitation, in engineering, We have the development of vaccination, the development of things like sanitary boards and public health boards, all these kinds of things. And what you see is that ID mortalities drop rapidly everywhere, but much more rapidly in the West. So I shouldn't even say rapidly everywhere, very rapidly in the West. And they start dropping, ID mortality stops dropping somewhat in the global South. So if you're looking over this long arc of history, what you see from about 1850s onwards is that infectious disease mortality has really become concentrated in poorer populations in poorer countries through this inequality wedge that, I mean, some would argue it starts even earlier in the 16th, 17th, 18th century, but certainly during the age of high colonialism, if you're looking at infectious disease mortality, this is where you really start to see these big changes. And it occurs through this inequality wedge, right? And this inequality wedge is driven by extractions in one direction from the colony to the metropole, innovations that are applied unequally, so vaccination more in the metropole are being vaccinated than in the colony, or the people in the colony are being vaccinated under for experimental reasons, or because they're being shipped in massive quantities to fight in World War I, for example, these sorts of things. So how those innovations are applied are unequal. Running water gets applied, obviously, in Paris before it gets applied in Bangalore, right? And of course, you see a deeply unequal wealth accumulation because of these extractions of the colonial state. So you see all of these changes that drive this wedge. And it's certainly not just infectious diseases. That wedge has repercussions for us in so many different areas right now, right, that we're living through. But in focusing on infectious disease, you can see quite clearly how this wedge works with infectious disease. And so if you look in the period post-World War II, this is in the age of decolonization, right? And so all of these colonial health structures and partnerships get converted into what we call international health. But the interesting thing about that period, about the 60s, 70s, even the early 80s, is that if you're writing a history of infectious disease, it's a really different history at this point from the sort of the global North, the West, and the global South, right? To the point where in the global North, there was this sort of hubris among public health practitioners, ID specialists, health experts, CDC, these sort of organizations, where there was this sense that not malaria, but all IDs essentially had become neutralized, not completely eliminated, but as a major public health threat. They had been neutralized to a point where they were more of a nuisance than a real threat. And what you saw, in fact, in Europe and the US is this confidence was at a high enough level that you saw the dismantling and the reduction of surveillance programs, of ID control programs, of these sorts of things. Not so much in the global South, right? The global South, their history of ID burden or ID mortality was hadn't changed that much in that 50s, 60-year period since the beginning of that century. But then we all know what happens afterwards with HIV/AIDS, which I'll talk about in a minute. So what you see in this period, let's say to maybe the early 80s, is that these diseases that were once significant killers in Europe and the United States had remained significant killers only in the global South. Diseases like TB, measles, malaria, whooping cough, Hep B, tetanus, diphtheria. I'll talk about AIDS in a second. Pneumonia, those kinds of things, which were such massive killers everywhere, were now really sort of global South problems. But this changes, of course, with the advent of HIV/AIDS. And so I'm going to give you just a few of these charts that I've sort of collected and also I've found online to sort of illustrate how this sort of the process and what I'm talking about. This is a WHO chart from 2012 that was sort of put out actually to educate people on the fact that IDs are a huge problem, and sort of giving you this really striking graphic of what a huge burden, they still are, right, globally. The thing that I find really fascinating is if you look at the grayed out areas, the ID burden is insignificant enough, right? There's not enough deaths per 1,000 that they don't actually show up in this colorful, sort of beautiful chart to show you about these burdens of disease. So this is sort of a visual illustration of the story that I just was telling you. They didn't intend it that way, but that's kind of how I read it. And I also wanted to emphasize that that particular chart, you might look at it and think, well, it's about tropical regions and hot temperatures, and maybe the geography of those regions are more conducive to vectors or these kinds of things. But this is a sort of a false argument, right? Because what history shows us is that that is not really true. Because if you look at the history of specific diseases, you see that they occurred in wealthy countries as well. And this is quite a famous map. This is a map of malaria in the United States in 1870. And you can see that malaria was actually a significant problem in 1870 in the United States, in big swaths of the United States. And if you even blow up the region of Cook County, we're still in this sort of middle area of the, on the scale of deaths that were attributable to malaria. So even the Chicago area was not free of malaria, right, in 1870. These are some other malaria charts. This is Italy in 1882, and this is a French medical map in the late 19th century. Malaria is Vivra paludien, and you can see at the sort of dark blue area where malaria was significant cause of death in those areas. And now if you look at malaria distribution, it looks, obviously there's nothing here and there's nothing there, right? It's this swath, especially here, that we're also so familiar with. The same thing for cholera. This is the third cholera pandemic that occurs in 1852. In the 19th century, there were 6 cholera pandemics about every 10 to 12 years that would sweep kind of from east to west, always across Europe, always across the United States, really across this band here, that caused considerable mortality. And these cholera pandemics created a terrible panic, and they really sort of helped to shape the public health world that we live in, even the global health world that we live in, because the sanitary conferences were first organized for cholera. The sanitary conferences of 1851 eventually become the basis of the WHO, right, after World War II. So we're living with echoes of these sort of ID histories. And this is cholera in 2022. And you can see the map has sort of moved down. We don't care about Europe or the United States anymore. It's, again, this band in the South. And this is where cholera is a big problem now, where it occurs regularly, right? Again, not we might associate it with the sort of tropical diseases, but it's not a tropical disease per se. And just to drive the point in, today there's a vast global disparity in life expectancy. It's driven largely by IDs, right? This is regional infant mortality rate. Sub-Saharan Africa, it's 51 per 100,000 live births, and in Europe, it's 4 per 100,000 live births, right? So you see this huge disparity that's largely driven by infectious disease mortality. And in the same way, you can look at life expectancy. And you see the huge disparity in life expectancy. Life expectancy in Sierra Leone, Guinea is something, I think it was like 55, maybe now it's 57, 58. And that's a good 20 years off of life expectancy in Japan, for example. So there's, these huge disparities that still occur. So thinking about it, so bringing it sort of into the more modern era and what the kind of policies that we are living under for infectious disease. Okay, so you have this heyday, maybe heyday isn't the right word, this period of confidence in the idea that infectious diseases are a thing of the past, or at least have been managed, are a nuisance rather than a huge threat. But then you see the emergence of HIV/AIDS in the early 80s in the US, in particular. And it really kind of knocks the ID community off of their kind of comfortable ideas about what was going on with infectious diseases. And various other infectious disease threats in the early 90s, the big cholera, Asiatic cholera epidemic in Latin America, the very strange Ebola outbreak in Kikwit, and the bubonic plague epidemic that happened in India in the early 90s. All of these things made ID specialists and the global health, at that point it was still called the international health community, a lot more aware of what was going on. Or I suppose a better way to say it's the instability and the continued risk of infectious disease. And so you see the development of this framework of emerging infectious diseases that was written up by Joshua Lederberg at Institute of Medicine from NIH around 1992. But this EID framework was picked up everywhere. The CDC, various medical journals in the next 2, 3, 4 years wrote special issues to emerging infectious diseases. And it really sort of took hold in the global health communities. And what you see today is that infectious diseases, it's particularly in the global south, they've been roughly split into these sort of 2 categories, right? The NTD category, I'm not going to talk about too much, the neglected tropical disease category. But that split for me is interesting because what you see now is often IDs are sort of framed as emerging infectious diseases and sort of threatening somehow to the West or to stability, or they are kind of I mean, NTDs are parasitic diseases generally, not all of them, but most of them, or they are sort of not a threat to the West, but they impact the poorest populations. And so they're sort of shoved off to the side. But you have advocates who are working very strongly to sort of bring the suffering of people with NTDs to attention. And the difference in the way those 2 sort of categories of disease are treated are very interesting to me as well. So I'm not going to really talk too much about NTDs, but for emerging infectious diseases, you have what drives the emerging infectious disease framework is securitization. And that securitization is really sort of central to many of our global health organizations. You know, the WHO, the UN, and at the government level, you have this idea of global health security, and the emerging infectious disease framework is really central to that idea, right? What is securitization? This is a quote from Claire Wenham. Health and security have been increasingly connected to the evolution of a particular predominant approach to the global health security narrative, not necessarily because a real existential threat exists, but because the issue is presented as a threat to receptive audiences. This has been called like the Copenhagen formulation of global health security or securitization. There's been so much written about securitization from the various different perspectives, speaking of the pros and the cons of it, but I don't think many of the analyses look at how it actually reinforces already existing historical sort of frameworks of inequity, which I think it does, right? How do emerging infectious diseases and securitization work? The EID framework in particular, it's reshaped that global health intervention and government's landscapes. It frames all kinds of illnesses or health conditions as risks, and it authorizes certain types of collaboration, certain types of funding, certain types of repressive measures, certain types of surveillance measures, certain types of control measures. What you see is that security responses and health policies are increasingly interlinked. And you see that health issues are increasingly folded into military budgets as non-traditional security threats, which it can kind of be a good thing sometimes, right? Because there's no bigger kind of funding pool than military funding. But the problem is it doesn't come without strings attached. And with that military funding and with this securitization ideal, you have a different orientation towards your health interventions and what you're doing with them, right? So when you're trying to think about those practices or the implications of this sort of framing of health in the securitization frame, what sort of are some of the results from that? You get this idea of health for security's sake. And again, it's not all negative. There are quite a few pros from that, right? If you pose infectious disease as national security issues, it brings resources to health problems, it brings social and political capital to the practitioners of public health, and it sometimes brings a certain level of cooperation among different sectors that might not necessarily cooperate with a health issue. We saw that first, I think, with HIV/AIDS. The UN Security Council had never discussed a health issue before they discussed HIV/AIDS in the early 2000s, but they brought it before the Security Council, and it authorized a certain sort of action against the HIV/AIDS pandemic, right? We see this as well with COVID, which I'll talk about in a minute. We might all be a little bit tired of COVID, but I will just briefly discuss. In terms of cons, securitization prioritizes those diseases that threaten national and economic stability. And because the security sort of complex or the security language, the securitization framework is guided by the global north, when I say threaten national and economic stability, it's usually global north nations. And economic stability is usually the economic stability of, the G8 or the OECD countries, right? It minimizes multifactorial causes of ill health. You can't really talk about poverty if you're focused on preventing the spread of a pathogen from one location to another, even if poverty is a driver of that spread, right? It makes it really complicated to talk about. And it encourages the militarization of health response. And again, we saw that with COVID. I saw that with Ebola. You have authorization to surveil people and where they're going. And this happened in South Korea, for example. You have the police use or police monitoring of things like curfew or lockdown, those kinds of things. So it's sort of a slippery slope. When you say that health is a security issue, well, then you can use security forces to enforce that issue, right? And this is part of the problem with that. The big kind of issue with securitization is that it skews that health response towards economic threats to wealthy countries, as I mentioned, and it doesn't do a great job sometimes of actually meeting the needs in particularly sort of localized outbreaks that are not threatening to wealthy countries. And one example from last year would be the cholera vaccine shortages. Millions of doses short. Many countries requested the vaccine. There aren't enough manufacturers. The vaccine isn't a terribly effective money maker. And then you don't get that funding for that production of that vaccine because cholera, while we have a good sanitation, water treatment systems, cholera doesn't pose a real threat to the West, to Western nations. And so you don't kind of get that activation of that kind of interest and that interference with the sort of natural market forces to effectively address the issue, right? Another way that securitization skews health response towards these economic threats to wealthy countries is the way that, and I think this has been maybe 10 or 15 years, it's been a little bit of irritation to me when I hear this talk about investing in resilience in low-income settings, especially public health systems, resilience or the basic structures. Because I often, in many instances, it's not about actually creating a primary health care system that is responsive and that provides good primary health care as much as it is about creating these sort of outposts in these remote areas or these sort of primary health care surveillance structures where the country has enough of a functioning system that they can pick up a strange a cluster of illnesses or something like that. It's not about treating people for maybe those diseases that aren't a threat externally. It's really about having a surveillance system in place to detect, for these possible threats under this securitization framework. Another point I will make is that securitization and neoliberal economics reinforce each other. Some of this I've already made, but part of this issue of securitization and this labeling of these threats sort of specific to pathogens, specific to outbreaks in this kind of way is that it also encourages these continued siloed, very technocratic, disease-specific responses for major diseases. And there's been a lot of studies and a lot of writing about how these vertical disease control programs are not the most efficient and are not sort of working fast enough against the rapid evolution of how IDs are developing to reduce those inequities. You also see that the infectious disease agenda is still being set by these big organizations that are still centered in the global north, such as the Gates Foundation, the Global Fund, PEPFAR. I mean, the Global Fund decides what their priorities are, and community health organizations have to write to and orient to and program to whatever the Global Fund is going to fund, right? And that's sort of that is a problem. And that is part of this framework that I'm talking about. And of course, we still have major influence of the World Bank and the International Monetary Fund, which are again controlled by the wealthy countries in all of global health governance. So it sort of furthers these sorts of inequities. And I wanted, let's see how much time I have, because I can also, I have enough time. I'm nearing the end here. So the example of COVID, if you look at the Accelerating COVID Technologies program and the COVAX facility that the WHO put together at the very beginning of the COVID pandemic, it didn't work well, right? It worked, in fact, kind of terribly if you looked at sort of how vaccines were distributed, how resources were shared, this sort of equitable risk pooling and resource sharing. It didn't, in the end, it didn't really work that well. There were some pros, right? It really, the ACT really pooled quite a few resources that really helped with coordination, and it helped to accelerate research and development. But at the end, I think what happens with ACT and COVID, a COVAX facility, the end result was that all of that coordination, it really benefited high-income countries first. And you also saw a diversion of resources in low-income and low-middle-income countries that we're still seeing today, right? It's sort of a knock-on effect that has devastated some of the aid structures for these low and middle-income countries. Even though, ironically, thankfully, I suppose, the disease itself, COVID, has had less direct impact, on these countries. And I think a lot of that can be attributed to this sort of emergency response kind of risk framework under which the entire COVID-19 response operated, right? So I think I want to wrap up here. Let me see how much time we have. Oh, no, I'm pretty good. So I want to wrap up the and hopefully we'll have some discussion because the critique that I have, or the critique that certainly not me, but just sort of a lot of people who work in global health studies sort of have is that when you're looking at sort of global health governance of infectious disease and the patterns of infectious disease that still are occurring globally, the problem is, of course, it's still controlled by actors in the global north. It's still technocratic and reductionist, and it still neglects what is the major cause of infectious disease death, and that is poverty, inequality. All the way back to the Thomas McCown thesis, it's not medical innovation and vaccinations that started to save lives in the global north. It was better nutrition, sanitation, built environment. That's when you really started to see those big mortality drops from infectious disease in the global north, right? And those kinds of things aren't being targeted in the global south. It's really these sort of technocratic interventions going after those specific pathogens. And the problem with the securitization framework, with the emerging infectious disease framework, is that thus far, as I've been watching it in the last 15 years, it seems to actually reinforce all of these kinds of factors that, although entirely unintentionally, continue to create that wedge, right, between outcomes of the global north and the global south. So this is sort of, that last question is impossible, but what's clear about infectious disease when we read it now, right, the evolution of emerging infectious disease is that they are rapidly evolving and growing as a major threat to human health. And it's for many reasons, because of climate change, because of intensified globalization, because of our food systems, because of destruction of natural environment and degradation, all these kinds of things we have been seeing in the last 10, 15, 20 years, more and more, both novel but re-emerging infectious diseases that are growing as serious problems. And of course, you have to add to that things like antibiotic resistance. We now have, XDR-TB. After XDR-TB, I don't know what happens, but antibiotics are failing us. Yeah, so there are all these various factors that dengue, for example, dengue right now, with the 4 serotypes and the sort of increased global distribution across different serotypes, and the fact that if you have if you had dengue from one serotype, you're actually at risk of a more severe reaction if you have dengue of another serotype. But now that the geographical overlap between these different serotypes is so common, then of course dengue becomes a much more deadly disease. All of these many factors mean that IDs are really growing as a threat. I think that's real. I mean, I don't think it's just this sort of post-COVID moment where we see it that way. I think it's really true that infectious disease outbreaks are growing as a threat. And in thinking about that, I wonder how we can rework this securitization model of infectious disease response to ensure greater global health equity. Because even as IDs are becoming more dangerous, I'm still not sure that securitization in the way that it works now will get us to a more equitable world where everyone is protected from infectious disease. Okay, and that is my talk. So I'd be happy to discuss, answer any questions.
Excellent. Dr. O, thank you so much. Let me see, I have a couple questions, and then I don't know if people can come off and actually ask their questions, be unmuted, but if anyone has questions, please put them in the Q&A, put them in the Q&A area and box, and then I will share them. But I think one of the things I was thinking of was exactly your last point here. I guess, do you have any ideas about how we could move away from this idea of securitization, this framework that does have some benefits in terms of wealthier countries seeing the threat that emerging infectious disease may have, but maybe, I don't know, is there a way to rework it? What do you think is a way to rework this so that we could improve inequity and not just keep, I guess, reinforcing the same bad habits?
Well, I think I think that it's sort of an impossible question because this is the framework that we live in, and it would involve to do it in a meaningful way would involve reworking that framework. But one of the things that I think, and I see that the Havey Institute does this, and more global health actors are at least trying to do it, is to include leadership from the global South in making those decisions, and not in kind of a performative kind of way, but actually giving them a voice in helping to direct and to shape, some of these interventions. That's one of the ways that I think that it could help.
Yeah, definitely. And I know you mentioned this idea of investing in resilience in primary healthcare and some issues you have with that. I totally agree with that. But how do we improve just identification of disease and treatment and improve outcomes really at that initial point of care, the initial point of contact when people, I guess, come into our health system, our public health system? Well, I guess after your time kind of working with Doctors Without Borders in the field, I guess I'd be curious on any insights or thoughts you have on how to we can shift that and improve that.
That's also a really hard. One of the
I
things
know
that
it's tough.
Borders does, for example, is they do work on these sort of partnerships like the Access to Medicine campaign, and this and then sort of trying to identify areas where there a certain need is there and there's no healthcare, and they will sort of send people out. So that's sort of something. But the problem, of course, is the whole financing structure um, uh, uh, of sort of health aid discourages building good primary healthcare systems, right? Because that's long term, that requires a sort of commitment over time that these short funding cycles do not allow. Aid organizations notoriously hate to fund personnel. They don't like to fund people. They want to really fund very sort of defined, contained interventions. And once you put personnel on that payroll, then it gets like a really slippery slope. But there has to be a way to sort of to change those priorities, where maybe you can get funding organizations to be willing to invest in something as mundane and not as sexy, and perhaps not as the numbers aren't as impressive, as primary healthcare, because of course another thing is the numbers game, right? Because funders want to see, they want you to count, whatever that impact is, reduction of mortality, morbidity, deaths from this disease or that disease with this outcome. But the problem is, if you're really looking at primary healthcare, it's going to be dispersed across a whole bunch of categories. And then that also, with the way funding structures worked now, it doesn't work, right? So perhaps amending how the funding is envisioned. Again, that's like a huge ask. I don't know how that
Right.
works.
No, yeah.
But that
So
would be fantastic. Yeah.
yeah, we've had some successes in that area. Within the Institute for Global Health, we have a number of different centers that many of you are familiar with, but since you're newer to Northwestern, just summarizing for you. But we have a center actually for global primary care that's actually been one of our most well-funded centers. And it's all because of, I think Robert Havey being a primary care physician, seeing the benefit in it, and him expressing to his patients and every other people the importance of it, and getting private donation, focusing on primary care in the global health setting from individuals in Chicago. So anyway, we're working towards it, I think, but there's a lot of work to do, of course. Any other comments or questions anyone has who wants to jump in? I think you're able to just take yourself off of mute and ask if anyone has any other thoughts or questions.
Oops. Sorry, I'm trying
It's
to.
okay. You can stop sharing if you want. Yeah.
Okay. I don't know how. Oh, stop share. There you go. Okay. Okay.
All right. Well, if anyone thinks of anything, I just have a couple concluding remarks, but if anyone thinks of anything, they can jump in. But thanks so much, Dr. O, for sharing your insights and expertise today. I think there's good, I know you've just been here at Northwestern for a few years, but it's good to know you. And I think there's a lot of potential collaboration. I actually have a class I teach on infectious diseases epidemiology, and I might see if you can come speak to them on this topic. It'd be great. So anyway,
Yeah.
it's great to make these connections. It's part of why we do these seminars and everything. So thanks for doing this.
Thank you for inviting me. I mean, I think it's really, like I was telling you earlier, I think it's been, for me, it's always just such, it's so difficult to try to do, I'm sorry, this room is hotter than, hell. And I closed the window so there wouldn't be any noise. But when you're working, when I was working with Doctors Without Borders and you're working on interventions and you're working on operationalizing and improving interventions, it's just such a different world than when you're looking at that, and you pull all the way back and you look at the big picture and you kind of make these critical analyses and to find those points where you can affect some sort of, or envision some way of making the two kind of ways of thinking about global health work with each other is really important but hard, right? So
Yeah, I think so. And everything you brought up today was really enlightening, I think, in the ways we need to be thinking. So thanks again for all that. And just thanks to the audience for joining us. And if you have any other questions or anything, we can get you in touch with Dr. O. Or if you're interested in collaborating with Dr. O, let us know. We can get you in touch with her.
thank you, everybody, for
Yeah.
silent Zoom audience.
So I just want to. Oh, go ahead.
Yeah, sorry, I couldn't put it in the chat, but I thought this was a really excellent presentation, very much in line with what a lot of us are trying to do. And unfortunately, Chad, as you mentioned, sometimes very hard to get this type of work funded. So I envision a lot of future emails for you and really wanted to thank you. This was very inspirational and thought-provoking.
Thank you.
Thanks, everyone. Yeah, so I just wanted to mention our next seminar. So invite everyone to join us for the next one, which will be a virtual, a Zoom-based presentation again. That's going to be on Wednesday, July 10th. And we will be hosting one of our long-term collaborators, and we'll be featuring Dr. Isaac Adewole from Nigeria for his presentation, Investment in Capacity Building and Research Development as a Catalyst for Sustainable Development, the Success Story of Northwestern University and University of Ibadan Partnership. We've had a partnership there for a long time. So Professor Adewole is an adjunct professor here at Northwestern and he's a professor in research and innovation at the National Institute for Cancer and Treatment in Abuja, Nigeria, and patron of the HPV Consortium at the College of Medicine at University of Ibadan. You can register for this one via our newsletter, Paint It Purple, or our social media pages. So take a look for that, and we hope to see you guys on July 10th for Dr. Adewole's presentation. Again, thank you to everyone for joining us, especially Dr. O. A recording of the webinar will be available online and will be able to be shared through our newsletter. Thanks, everyone. It's good to see everyone, and we'll see you next time.
Thank you.